Reliable assessment of hand and wrist trauma is vital in ensuring that injuries are triaged correctly. This video will explain general inspection and palpation of the hand, examination of the vascular status, the neurological status, and assessment of tendon function. With the patient exposed to the level of the elbow, inspect the front and the back of the hand. Make a note of any discoloration, swelling or deformity which may indicate an underlying injury. Document any breaks to the skin integrity such as lacerations or abrasions, and palpate any areas of concern for bony tenderness. Fractures of the scaphoid bone are often missed on X-ray. Check for these by direct palpation of the bone in the anatomical snuff box. This is the soft triangular depression at the base of the thumb, bounded by the extensor and abductor tendons. With the wrist in slight ulnar deviation, the bone can be felt in this area. Pain here on axial loading of the thumb may also help to confirm any clinical suspicions. To assess the vascular status, start by assessing the colour and temperature of the hand. A warm pink hand is likely to be well perfused, whereas a cool, pale hand may represent ischemia. The radial pulse should be palpated just radial to the FCR tendon on the volar aspect of the wrist. Finally, assess the capillary refill time by blanching the nail bed for 5 seconds. On releasing pressure, the colour should return in 2 seconds or less. To assess sensation, apply light touch in the distribution of each peripheral nerve. Compare to the unaffected side and document if it is equal, absent, or subjectively reduced. Reliable areas to test each nerve are in the first dorsal web space for the radial nerve, the volar aspect of the index finger for the median nerve, and the lateral border of the hand for the ulnar nerve. To assess the motor function of the radial nerve, ask the patient to make a thumbs up. Isolate the interphalangeal joint as shown and test extension against resistance. To assess the ulnar nerve, test the power of finger abduction. Ask the patient to spread their fingers as wide as they can and again test against resistance. To assess the median nerve, the patient must perform 2 movements in one in order to make an OK sign. This requires them to oppose the thumb and flex at the interphalangeal joint. If either component is absent, they will not be able to make a perfect circle. To test the power of this movement, use your own finger to try and break the ring. There are 3 sets of tendons to assess in the hand. The first runs on the dorsal aspect and creates extension of the digits. The second 2 both run on the volar aspect and create flexion. To test the extensor tendons, ask the patient to extend the digits and assess for power at the metacarpophalangeal joint. Extension of the interphalangeal joint may be due to the intrinsic muscles and is not a reliable marker of tendon function. The flexor tendons are divided into deep and superficial groups. The deep group attaches to the distal phalanx of each finger and can be assessed by isolating the distal interphalangeal joint and asking the patient to flex the digit. The superficial flexors attach at the middle phalanx of each digit. Both these and the deep flexors can produce flexion at the proximal interphalangeal joint. In order to remove the effect of the deep group, hold the other digits in extension. When the patient attempts to flex the fingernail, only the superficial group will be active. This should produce flexion at the proximal interphalangeal joint only.